So the first one is for Lisa, and the question is, with such a low functional literacy among U.S. citizens, less than 65% high school graduation rate, and less than a third of college students achieving proficiency in understanding of complex issues, how do you expect most Oregonians to use the information from the Oregon Health Insurance Exchange? Has there been a demonstration project to show that it works?
That's a great question. So Cover Oregon is going to be offered through the web portal, and so people will be able to go there to search for plans. And as I mentioned, we are doing some usability testing right now to get folks in. We're going to have a prototype in a few weeks so that people can actually click through and we can kind of see what they're doing and how they're reacting to certain things on the site. And we understand it's a really huge task to make this understandable. We're also putting together a network of people who can help with enrollment, because we know a lot of people are going to want one-on-one assistance. They're not just going to go on the website, or they're going to go on and they're going to have lots of questions because they're not going to understand, what's the difference really between this plan and that plan? What does this mean for me? So we're going to have a network of insurance agents throughout the state who are going to be affiliated with Cover Oregon, and they're going to be able to sell all the plans on Cover Oregon. And then we're also developing a network of community partners that will be working with folks. These could be community organizations, chambers, providers, any number of types of groups who can really get out and work with folks one-on-one. So that's kind of how we're tackling the assistance piece. We're also going to have a customer service function within Cover Oregon that can do some assistance, but we're going to try to push a lot of that assistance out to the communities, because those are the people that people trust, their insurance agent or their local Boys and Girls Club or whoever that they go to for trusted information.
Right. This one is broken into two: question of the panel and question of Samaritan. And I'm going to do my best, just general disclaimer across the board, to read what the card says. If I make an error, it's my reading abilities that are off. So this is an A and a B, so for the panel, and then for Samaritan. The medical loss ratio for Medicare is about 97%, e.g. its overhead costs are about 3%, while the medical loss ratio for private insurance is 80% under the new law. The differential could support more health care. So how can private insurance continue to be justified? And the second question was, what is the medical loss ratio of Samaritan systems?
Let me take the first one. Obviously, getting a lot of the administrative waste out of healthcare is what we've got to do. And for instance, in the Oregon Health Plan, the medical loss ratio for most of our plans is somewhere between 92 and 94%. And to do that, plans are also doing enrollment and a variety of functions that actually that previous question really talked to, which is a fair amount of patient education and engagement and a variety of functions. Let's be clear, any dollar that goes to administration and that doesn't go to basic health care is a dollar that could be spent better. I think the goal of our local coordinated care organizations is to have them run as lean as possible, have them put those dollars into health care, and ultimately to hold them to outcomes. And that's going to really be the proof of the pudding. As Charlie said, the young boy Malik, who is a great example, think for a minute, if the goal of the Oregon Health Plan is no child with asthma should ever end up in the emergency department. That's actually what we should be working towards, rather than more and more care or more and more administration.
So we're going to stick to the cards. I know everybody's really passionate, but we're going to stick to the cards.
I did. I said that we need to get less money that goes to administration.
Kelly.
So for us, for IHN, we run right around the 94%. So we spend about 6% on administration and 94% on paying for care. So answer that part B.
All right. The next question is there adequate capacity now, enough providers, to provide adequate mental health services to meet Oregon Health Plan members' needs. And I would add a second piece onto that to meet the mental health care needs of everyone in our community, whether they're Oregon Health Plan or otherwise.
Want to take that, Mitch?
Sure. In my estimation right now, at least in Benton County, I can't talk across our whole region, but I would guess this is the case, that currently there is not adequate capacity around mental health care in the community. For those who are involved in that system at all, mental health care takes a huge amount of community support for people with a chronic illness like and we're just slowly building that system now. Again, I think the hope would be that again, it fits right in with the initiative of the CCOs, which is to move more care out into the community and help support people being well, rather than waiting until they get very sick and end up in the hospital and things like that. So I think that there may be the capacity. The challenge is, and it's the discussion all the way through the health reform has been, on the one hand, there's this idea that there may be enough money in the system. It's being spent in the wrong places. But the issue is, how do you disengage where it's being spent now to move it where it needs to be spent? And that's the tricky equation in this, because it'd be a lot easier if there was a whole influx of new money and you could start up new services and then fade out on the old, but we don't have that luxury. So I think that's where we're working on transition plans and really thinking strategically about how do you do this? How do you create some savings that you can then reinvest in more upstream solutions and slowly kind of bend where the emphasis is. So we need to build capacity in the mental health system. We've got to figure out how to do that by saving in some other places.
Training more people.
I would just add that I think that's a lot of the focus of our transformation is really around mental health and physical health, and how do you get the right care or the warm handoff at the right time in the right place. And is that going to be an opportunity? Because as Mitch mentioned, there is no additional money. So there's more opportunity and more work and more challenges. And so we're doing all that with what we have today. And so we're having to be creative and be innovative. And that's with changing that care. And as he mentioned, you can't just sort of, it's like moving a cruise ship. We're not just going to, turn the boat really fast and go in a different direction. It's a process that we're working through, and we're trying to make sure that wherever we put our energy and our focus is hopefully getting us the biggest bang for the buck as we start to make those turns so that we get the outcomes that we're looking for the citizens that we serve.
There's no doubt that we need more primary care and primary mental health capacity in our communities everywhere around the state. And I think our goal is to look at how we can begin to move resources from expensive tertiary end-of-the-road treatments into more primary and preventive care. Let me give you an example of what happened out in a community like Bend, where looked at the 100 people that had been going to the emergency room most frequently. It turned out that the vast majority of those individuals were young individuals on the Oregon Health Plan going to the emergency room for headaches, abdominal pain, a variety of physical complaints. When the issue is that they really needed access to good mental health and addiction services. The community got together, created a number of individuals to help get those individuals into mental health services. Resulted in savings in a variety of hospital and emergency room costs, and those dollars in the community being able to be transferred into developing the kind of local mental health capacity that a community needs. So I think that the goal of all of this is to be able to move resources from things that can be prevented into the sorts of primary mental health care to avoid crisis services, expensive care that can be avoided with good access to primary care and primary mental health care.
And I am looking at scheduling a follow-up forum, probably sometime around February or March, that would focus primarily on mental health care in Benton County, including kids' mental health and the kids' mental health system. I think there's a lot going on in the community right now, and it probably would give us plenty to talk about in its very own 2-hour period of time. So the next question is, please address the revenue stream that Oregon needs to generate to get all or close to all Oregonians covered by insurance. And there is a note on the card about the news earlier this week from the governor talking about an extension of the hospital tax, of the provider tax.
So, yeah. So I don't have the figure for all to cover all Oregonians off the top of my head. So I'll have to get back to you on that one. But I know what it will cost us for the next biennium to begin to assure that we can cover everybody under 133% of poverty in the Oregon Health Plan. And that's about somewhere in the range of about $10 billion for 2 years. And
Billion or billion?
10 billion with a B. To cover the approximately 700,000+ people who we anticipate will be on the Oregon Health Plan over the next 2 years. The cost for 2 years is about $5 billion a year, $10 billion a biennium. That comes from a variety of sources. We call the Oregon Health Plan, we think it's ours. Actually, the biggest funder of the Oregon Health Plan is the federal government. And the feds pay about 63% of the costs, and the state pays about 37% of the costs. And that 37% that comes from the state comes from a variety of sources. Generally, every biennium, as Representative Gelser knows, we cobble together the funds for the Oregon Health Plan from about 3 or 4 different sources. We use general fund dollars, those are general tax revenues. We use tobacco tax revenue, those are dollars that come from the taxes on cigarettes. We use a small amount of lottery funds, and for the past several years we've used a tax on hospitals as well as a 1% tax on insurance companies that has gone in to cover the Healthy Kids Plan. We hope to be able to move away from the insurance tax over the next year and be able to fund the Oregon Health Plan on the combination of general fund dollars, tobacco tax, and hospital tax.
Senate Bill 2002 put small businesses, sorry, let me start over, and quickly, it's 5 minutes till 8, so if your car is in the garage, this is a really good time to get it out. Senate Bill 2002 put small businesses with up to 50 employees into the insurance pool with businesses with 2 to 25 employees. My small business experienced a 50% increase in our health insurance cost. The employee count stayed the same, but the benefits decreased. The federal small business tax credit is available for businesses with up to 25 full-time employees. Is there a move to coordinate state and federal programs or something else to help businesses with 25 to 50 employees? And this is from one of our local businesses.
Trying to think if the Cover Oregon is going to be available for employers with up to 50 employees. And you are correct that the federal tax credit for businesses does just go up to employers with 25 or fewer employees. And we, coming through Cover Oregon, we are going to, be offering more options for employers to help hopefully make it easier for them to offer plans to their employees. Right now, I know a lot of smaller employers and kind of mid-sized employers as well, have a hard time picking one plan or one company that meets the needs of all of their employees. And so Cover Oregon will offer an option for employers to be able to give their employees a set amount of money, and they'll be able to shop for any plans that are offered through Cover Oregon. So we think we'll be offering a lot of broad choice. I'm not aware of any efforts in terms of, changing, the federal tax credit is really just for, 25 and under. I'm not aware of anything that would change that. But I could also follow up with the insurance division that regulates companies to see if they know of anything going on.
I have the contact information on that card, so we'll follow up on that afterwards. How will Obamacare affect health savings accounts now and in the future?
The health savings accounts will still be available to individuals who want to be able to set them up, or employers that want to set them up outside of the insurance exchange. There's no plans right now to offer health savings accounts through the insurance exchange, and I don't believe that the Federal Affordable Care Act directly addresses that.
I don't believe so, but again, we're happy to follow up on that question too.
And there wasn't contact information on that card, but whoever wrote the question knows that you did. Find me afterwards and we'll follow up with you about that. The next question, Samaritan Health Services has a very dominant role in healthcare delivery in Benton County. Now that the local CCO is also under the umbrella of Samaritan Health Services, how can residents and private providers ensure that there continues to be choice in healthcare service in Benton County?
So I think that there certainly continues to be choice and access in Benton County. That's something we've worked for a number of years. I've been working with in our Community Health Network for 17 years, and we've been administering the Oregon Health Plan here. And we have been administering that as a community-based plan, collaborating with independent providers, the Corvallis Clinic, Public Health, and that won't change. That hasn't changed. That's actually the collaboration has gotten better. Our integration has gotten better, our communication has gotten better. And so I really think that the CCO is actually changing the way that looks and making it broader and more open. And I think that you will see that it continues to be inclusive and involve all, any provider who will would like to work with us to serve some of our members. We're willing to work with every provider and always have, in terms of if they meet our standards, in terms of credentialing and those pieces. But we continue to be a community-based plan, and we'll continue to do that as we move forward in the future.
So this card also has two questions, one for Dr. Goldberg and one for Kelly. So Dr. Goldberg, you said that 95 to 96% of folks will be covered. Who are the 5% and how do they get coverage? And then the question for Kelly, it says, Kelly, the RPG, you didn't mention the Corvallis Kaiser Clinic as part of the group. Oops, or is there a reason?
The 5 or so percent of people who probably won't have health care fall into probably two big categories. One are those individuals who are not citizens and are ineligible for Medicaid in the Oregon Health Plan. And the other will be individuals who will choose to not buy coverage through the health insurance exchange or choose to self-insure themselves. So it'll be a combination of most likely those two groups. Just to back up and let people know how federal reform, Obamacare, really covers people. All individuals under 133% of poverty will be able to come into the Oregon Health Plan, except those individuals who are not citizens of the United States. Above 133% of poverty, there'll be the opportunity for individuals between anybody to buy health insurance on the insurance exchange. The cost of that is subsidized somewhat through tax credits for those individuals between 133% of poverty and 400% of poverty. Above 400% of poverty, there is no subsidy, but individuals under the mandate to have health insurance will still be required to cover themselves. There are, however, individuals that will choose to pay the penalty and to not insure themselves, or individuals who just will not avail themselves of coverage. They won't sign up for the Oregon Health Plan, they won't sign up for the insurance exchange for whatever reasons they may have.
And I just realized it said, okay, Kelly and then Kaiser next to clinic. I think it's Kelly Kaiser. Okay, the Corvallis Clinic. Sorry.
Kelly's actually the head of Kaiser.
I am not the head of Kaiser.
Any problems that anybody has with Kaiser, you should just direct to Kelly. I do.
So no relation to Kaiser Foundation. But the Corvallis Clinic, I think, is what you're referring to. And they actually are on our regional planning committee, on our delivery systems transformation committee, on our finance group. and will most likely be on the board shortly. So very much involved and very much integrated.
There's a lot of questions for Kelly. Will the CAC meetings and the CCO board meetings be open to the public?
So the CAC meetings are open to the public and have a public meeting comment and have that all set up for that. And that is part of the legislation and as it came forward. The board meetings are not considered open public meetings. Mostly that was not written into the legislation. We had a very lively discussion about that at our board meeting to talk about how to move forward with that. And at this time, due to the public-private nature of our partnership and all of our stakeholders around the table, we don't have those meetings as a public meeting. That doesn't mean that we're not out there sharing information or available to talk. We have 3 community forums starting next week where the board will be available in each county to answer questions of the community and be able to get feedback and process that information. And that was one of the things that we promised our community when we came together and had some public forums a couple months ago, that we would, on a quarterly basis, make sure that the board members were available for discussion. So it's just the meetings themselves that are not public, but the information continues to be shared through the CAC, through the Regional Planning Committee, and out through our public forums of the board as they go out each quarter.
I have not heard any mention of prevention and wellness components and strategies. Please describe how these aspects will be included and how.
Oh, they're included. Oh, yeah.
Got lots of focus.
Prevention is, sorry, I can't remember the one that's close. Prevention is a large part of what we're doing as a CCO. Many of you might have heard the term population health. And with the advent of the CCO, we've really taken a new focus on just what population health means. And population health, for those who don't know, means focusing on all the determinants of somebody's care. That means all the things that might be involved in a person's life that might lead to an eventual health care issue. For instance, if we take the young boy here, right? His living conditions are one of the things that are leading to his asthma. If I remember this case study, he didn't have an appropriate vacuum in the home. And the lack of appropriate cleaning utility tools is one of the things that was leading to him going to the ER. That's called a determinant of care. It's part of what we consider when we look at population health. And so as we look at prevention as CCO, we're no longer looking at prevention as just colonoscopies and mammograms. We're looking at it from a population perspective and a holistic perspective so that every member's needs will be addressed and hopefully prevent an issue from occurring in the future. And therefore, we're going to reduce the cost of care.
Yeah, again, this is a piece that public health brings. The prevention pieces that occur in your doctor's office, the screenings, those kind of things, are what public health calls secondary prevention. So they're very often dealing, as with this young man, with a problem that already occurs, a pathology that already exists, keeping it from getting worse or reoccurring. The community coalitions, the community outreach, the community involvement that public health brings is really that upstream piece, improving the determinants of health, reducing the risks in the community, in our environment, reducing toxins, reducing exposure to illness and injury.
So I've got two for Lisa that are along the same line. So the first is, and I'll ask them both, the first is, what income is the cutoff between Medicaid and the exchange? And the second is, as a self-employed person, I pay $675 a month through Regions Blue Cross Blue Shield. Do I have to drop my current coverage to be eligible to participate in the exchange? What are you anticipating the range of monthly premium are likely to be? Please save me money.
Okay, so I don't have the income table in front of me, but the cutoff, it's, for Medicaid, it's 133% of the poverty level.
Which is what?
Yeah, just to give you a sense, for family of four, for family of four, the poverty level is a little over $20,000 a year. So for 133% of poverty, it's about 25, 26. Here we have the exact. We have the exact. Well, we don't have 133%. For 100% of poverty, it's $22,350 for a family of four. For an individual, it's $10,890. And so 133% would be about $13,000 or $26,000 about for a family of four. The way the federal poverty level works is it's based on family size. So one person, it's 10.9, and then it goes up based on the number of people in the family.
Yeah, and then for the tax credits that will be available through Cover Oregon, it's up to 400% of the federal poverty level. And I know that's for a family of four, that's a little over $92,000. So it's really a majority of Oregonians who will be eligible for the tax credit. If you do have another plan, you can go through the exchange to shop around and find a different plan. And so we'll encourage people who already are covered by individual plans to come and see what's available through Cover Oregon. And we're actually hoping that sparks some price competition, because you can go, if you have Regents, you'll be able to go to Cover Oregon and see the type of plan you have, and then not only look at Regents, like you might have done otherwise, but look at all the plans and all the prices and really figure out the difference between them. And then we don't have information yet on premiums. And so we likely won't have exact information until when we get close to launch. The insurance companies have to file their rates through the state insurance division. And they will be starting that process, I believe sometime in the spring, actually in April, they'll be starting to submit their rate filings. And that is a public process. They have public hearings on many of those filings. And so if you want to know what's going on, you can check out the insurance division for some earlier information on premiums.
Are we in any position to know?
Sam, we're gonna go by the cards. I'm sorry, but you can get another card.
It's part of the question, though. I mean, can we already anticipate that premiums are going to be coming down right out of the starting gate with so many more people buying these?
No, I mean, actually, the insurance division commissioned a study to look at the impact of federal health reform on premiums. And on average, they may actually go up a little bit because you are initially, because you are covering more benefits. The federal health reform requires plans to be more comprehensive and cover more benefits. So you may see prices go up. With the tax credits that are going to be available for the average person, they will go down. And that's why, though, things like the CCO concept are so important. Those types of efforts, it's starting in the Medicaid population, but at Cover Oregon, we're really engaged in those discussions as well, and our goal is to implement that into commercial plans that are offered through us so that we can really impact costs.
I think Charlie's going to want to jump in on this one. Why continue to have state-funded county health services? Public health, why?
To improve everyone's health and reduce costs. There you go. Basically, another point that I'd like to make is public health has reach into high-risk populations. Bruce talked about this study in Bend and looking at the most frequent users of emergency rooms and the mental health overlay that was a contributor to that. A lot of the populations that are underserved or suffer from health inequities and health disparities in our society are exactly the populations that public health is most engaged with. The minority populations, the homeless populations, the substance abusing populations, the injection drug user populations. The people that are really marginalized are the people that public health works very hard to get the closest to and engage the most with. This goes back to the earlier question about health literacy and access. Public health has access to a lot of those communities and has a huge amount of expertise already in communicating health issues and health information in different languages, at different levels of understanding, in an accessible manner, on people's home ground. They don't have to come to us. We're not in the office. We're out in the community, right with them, on the street, in their places of worship, in their schools, in their neighborhoods. And that's the value added of public health. And until, we really have raised all the boats and we don't have this constant pressure of increasing disease, and especially chronic disease, we need to be doing that prevention, and that's what public health does.
And I actually just wanted to add on that and just say, as a CCO, there is no way that we could do what we've been tasked to do without public health, long-term care, and many of our other community partners. We aren't experts in many of these things. We're looking to our community partners to be those experts and to continue to be those experts. And our goal is to collaborate with them, to learn what we each are good at, and then to reorganize in a way that maximizes all those pieces for the benefit of the community.
There's one other really important function, or a couple of important functions for public health. We've been talking about all the individual care, but every morning when you turn on your tap for water, that water is tested and we assure that it's safe through your local public health services. Restaurant and food inspections. The fact that when someone in a community gets a communicable disease, the tuberculosis or a variety of other things, the ability to assure that that doesn't get spread and to do those evaluations is a real important function of public health. I think we continue to need that. The problem for so many years has been that our public health departments and our public health system has been there as the caregivers of last resort for those people that our healthcare system has failed. I think that as we get more and more people who get access to basic health care, it's actually going to allow our public health system to play the critical role that it needs to play, which is keeping all of us healthy and having some responsibility locally for that. So I think they're still going to need a very strong role for public health around environmental issues, around communicable disease issues, and around helping us be healthy in those ways.
So we have a couple of more easy questions before we get to the more heated questions. And as we get to the heated questions, I want to
warming up.
We're just warming up. And so I just want to acknowledge that people feel very strongly about a lot of these questions. And I know that you may disagree or not like some of the answers, and I really appreciate that. I want to make sure we get through as many of the questions as we can. And if we have time at the end, we'll have more room for kind of follow-up and response. And the only reason I'm asking that we stick with the cards is so we can get through as many questions as we can. I know that means that we're not getting the answers as completely as you might like them, but we'll do our best to do that. And we have a lot in the legislature where we'll be responding to a number of these things, and I'll schedule a follow-up meeting with all of you and me so we can have more of a free-flowing back and forth like we usually do at the forum. So my apologies in advance. I anticipate people will start getting frustrated in a little bit, and also as it's getting late, but we're going to try to get through all these questions, and I want to thank all of you for answering them so well and being so willing. Okay, so this one's not hard. Until nutrition is allowed and recognized, taught, practiced, and wound in as a core, fundamental, and central focus of healthcare, results will be poor by human health standards, highly expensive, and not able to serve all the needs to get people better and ameliorate disease. Is nutrition talked about as a core concern needing to be built into the CCO program?
Definitely. That obviously goes back to the population health and that whole engaging our community and engaging our members in terms of their wellness. And that's not just your doctor visit, that's everyday choices, how you live your life, how you choose to engage, and nutrition is a huge part of that. And I think that goes back to public health, what's in the schools, what's available in the community, and how we address and tie all those pieces together, again, are really all part of not necessarily the CCO, certainly part of something that we need to continue to focus on, but it's really part of something all of us as members of our community need to engage in and be part of. How do we address and make those choices every day?
Yeah, you know, again, one of the biggest challenges in this whole operation is this sort of paddling upstream. And when you think about physician's office and how people are sort of pushed through their appointments really quickly under the old system, it's because doctors are paid by the visit. So the more visits, the more money, you gotta make a certain amount of money in order to keep your practice going. And one of the biggest challenges for the CCO is for us to figure out ways to begin to incentivize a change in that practice, which slows it down to some degree, so that there's time to address a broader range of issues when you go in to see the doctor, so that you better understand, they better understand you, and you come up with a plan. And that's gonna involve, we hope, broadening it out. Talk more about nutrition. You know, I find myself always frustrated when you go to the doctor and the quick answer is, here's your prescription, see you later. And what we want to get to is that there's more of a dialogue there and more looking at what's the whole scope of issues, what are the alternatives. But that's going to take some time. That's one of the hardest things to begin to shift, is how do we change the way the practice runs. It's changing a whole culture that's built up for years and years and years based on the way it's funded. So we've got to change that funding and incentivize it differently. And that's a big change.
To kind of bring it down to a practical level and help everyone see what that would look like and what really the CCO means, I think that's a really good place to start. If we look at nutrition and we say, okay, every child by the time they're in grade school should have an idea of what basic nutrition is. And every child at every stage should have more of an idea as they grow and they change and their lifestyle changes and their ability to understand should change. And so we, as a CCO, as we collaborate with our community partners, we're saying, when are you touching that child? When are you getting involved? What's your touch point? And what, doctor, what's your touch point? And that child might have mental health, might be involved in a mental health support group with their family. So maybe the mental health needs to involve nutrition in what they're doing. And the primary care physician, as they see the child, needs to address nutrition there. And through the public health system, we have the school-based counselors, and they're addressing nutrition there. And by all working together and understanding where each of us are interacting with that child, and that each of us are addressing nutrition as we interact with that child, then 5 years, 6 years down the road, that child's going to understand and have all the pieces to address their health in a very effective way.
I would just add, this isn't solely an issue around CCOs and Medicaid. This is actually an issue for all of us as a society. So much of our health is about our nutrition and what we eat. And in many ways, we have a medical care system that's really failed us around nutrition. Just to give you a couple of examples, we have the WIC program, a national program for women, infant, and child nutrition. It was only a year and a half ago that it covered fresh fruits and fresh vegetables. Think about that for a minute. I've got 2 children with chronic diseases, both of which have a huge nutritional component. I have outstanding health insurance coverage, and it doesn't cover the nutritional services that my kids need. This is a huge societal problem, and we've got to address it with broad societal interventions.
How do we drive competition for cost of care when we have a virtual monopoly in our community? For example, a simple MRI in Corvallis is twice the cost of a private MRI company in Lebanon, Oregon. We need transparency and skin in the game to drive the cost curve. How can we make that happen?
It's a great question, and it's one of the things that came up a lot in our discussions around CCOs and around healthcare. Right now, the the model we have of some competition in healthcare really hasn't worked. We've continued to see prices increase and quality degenerate. Our sense is within certainly CCOs, the way to deal with this is to maintain a fixed budget that grows at a sustainable rate at 3.5%. And that hopefully what that will do, combined with holding organizations accountable for outcomes, for clear deliverable metrics, that's going to result in the appropriate utilization of healthcare services, and that a CCO, being a group of healthcare providers, isn't going to be able to spend $3,000 for an MRI when it could get that for $1,000, understanding that they have to live within a budget. So we hope that that will work. In terms of, we often hear the term skin in the game, and certainly that's been a big issue nationally as well as in the state, about also individuals' responsibility for having quote-unquote some skin in the game. In the Medicaid population, what we know is that these are our most vulnerable citizens who oftentimes don't have any dollars, and we did an experiment, quote-unquote experiment, with this in our state several years ago when we required folks on the Oregon Health Plan to pay for portions of lab tests, medicines, and a variety of other services. And in looking at it, what we found is that many people often didn't get, because they couldn't afford the $10 for a medicine, they didn't get it, and they ended up in the hospital in the emergency room, and it cost more money in the end. We've got to be good consumers. I think it makes sense for those that can afford to have some responsibility for some of the payment to do that. We also need to have price transparency. No one knows what anything costs in our system. The providers don't know what it costs, we don't know what it costs, and before you have any skin in the game, you've got to actually know what the game is, and we have a terribly, terribly non-transparent healthcare system where we don't know what we're paying for, we don't know the quality. I can't understand a healthcare bill. My dad calls me every month, and the same thing. It's really sad. He gets his bill from Medicare, and he says, "Bruce, this isn't fair. I really like my doctor. The bill says X amount of money, but he's only getting paid $40. How come he can't get the other $50? How?" And he can't explain it. I challenge anyone to be able to understand their explanation of benefits and their bills, and what is a bill, what isn't a bill. You get something, it says, don't pay this, it's not a bill, but it says balance due at the bottom. It's absolutely crazy. And until we fix all of that, and that gets at the administrative expense we talked about earlier, we're never going to have a functional healthcare system. I don't know if anyone else wants to rant on that a little bit.
You did a great job ranting. So I was just...
we're mad as hell.
So I just wanted to respond in terms of the balance within the community and how we look at those things. From an IHN CCO perspective, we've got a broad group of people that are stakeholders that are involved in our decision-making process from a clinical perspective, an administrative perspective, and a financial perspective. And again, we make sure that we make those decisions based on what's best for the member and the service that's provided and the quality of that provider and the outcome. And so we are not specific to one area or one provider. We really make sure as a community that we're meeting the needs of that member given the access and the options that we have in our service area, and it is broader than just Samaritan. It's much broader than that in terms of who's making the decisions.
It really wasn't a rant.
That's okay, that's good.
Are the CCOs initially being set up solely to serve people on the Oregon Health Plan or to serve all Oregonians? Will residents of Benton County all be required to seek services through Samaritan providers, or will they still be able to see non-Samaritan providers? Will all insurance providers continue to be able to offer plans and coverage in Benton County?
Right now, the CCOs are being set up in the Medicaid program. And that's the only place that they exist. And as I indicated, they've existed for 105 days yet. So until we go any further with this, we've got to show that actually there's some value, that this can work. This is really a proof of concept. I think if we can show that this works, the question isn't so much about a CCO as an organization as it is about a model of care and being able to have a model of care that works to do the three things we've been talking about tonight. Improve health, be something that's affordable, and improve quality and all of our experiences in our healthcare system. Ultimately, there's likely to be, no matter what happens, and a variety of choices for individuals in communities. But I think what we're trying to do with this CCO model is to show that if you get those within the healthcare system, the providers of care, all together rather than competing with each other, along with consumers to work together, that all healthcare is local, and that hopefully this is a model that can work to get at those goals. Where and how it'll go from there, we don't know.
So in terms of the second part of the question, will patients or members need to be restricted to a Samaritan provider? And the answer to that is no, and never has been. Again, we've been administering the Oregon Health Plan here in Benton County for almost 18 years since the Oregon Health Plan started, and we have always contracted with the Corvallis Clinic, the independent physicians, Samaritan providers, and that has not changed and will not change. Again, back to our stakeholder group, which is actually grown from just a physical health focus, which is our historic focus, to one that includes mental health and eventually dental health. So it's actually getting broader and bigger than it already was in terms of the access on the panel. So it's not limited and never has been.
What happens if a CCO patient is unhappy and wants a different doctor?
Well, I hope they would call our office and let us know, and we will reassign that patient. That's the current process, and that's the process going forward. One of the things that I think we would all agree with is that your relationship with whatever care provider you see has to be a trusting one. You have to be able to trust your provider because you're giving them a lot of information and you're expecting a lot back. And we respect that relationship, and we want to ensure that all of our members have a relationship where they can build with their provider, a relationship of trust that they can build and take the guidance of the provider and ask questions as appropriate.
Another one for Kelly. Will the draft transformation plan be presented for public review and comment before it is submitted to the Oregon Health Authority in January?
I'm going to pass that one to Kim. She's been working on the transformation plan.
So the transformation plan is a work in progress between us and the state of Oregon. So the state of Oregon will be putting out guidance soon, I think, on further explaining what their expectations are related to the transformation plan. So until we have that guidance and understand what the expectations are for us, we can't set expectations for the community. But as soon as we have that information, we will definitely be sharing that out to you all.
And the Community Advisory Council will also be seeing that and part of that, so that open forum will be a place to be able to comment and give feedback. We're just waiting for the official rules so that we make sure that we're playing in the right ball field.
And I would just add to that a little bit of a different perspective, which is that this is hopefully going to be evolutionary, and that this plan that people put together and that the organization puts together hopefully isn't going to be static. It's actually going to be something that develops over time, that gets greater and greater community input, greater and greater information, and that changes and evolves as the needs of a community change. I think that's the only way it's going to be successful. And so hopefully it will become a part of the community. That's certainly been our hope.
I am worried about health insurance companies bailing out on the exchange, Cover Oregon, which will give the consumer less choice. How will the exchange cover Oregon? Keep a variety of options and choices, including non-traditional medicine choices.
Well, that's really, part of our mission and part of what our goals is to make sure there's adequate choice throughout the state. So we're really going to be monitoring that very closely. From what, we're working really closely with the carriers now that are in the market. And, from what we can tell, we think there will be very good choices throughout the state. But like I said, if that changes or if there's indication that there's an area of the state that's not well served, we plan to address that and work to get some good choices available.
As a board member, this is one of the things that I think has been, one, a lot of discussion, and two, something that kind of keeps all of us up at night. On one hand, the question is, what's the right amount of choice? And there's been a lot of debate about that in the state, about whether is 3 plans enough choice, is 5 enough choice, is 10 enough choice. Sometimes there may be too much choice. And then on the other hand, exactly what this question really referred to is, if we build it, will they come? And will we have enough choices on the plan to start from? So I think that the staff of the exchange and everybody is working hard to really strike that right balance between what is adequate choice and what isn't. And then the other big issue is affordability. And I think we all know that affordability isn't a static thing. What's affordable to one person is, quite frankly, not affordable to another individual. And I think that's something that we're going to grapple with and is going to evolve over time.
Will naturopathic chiropractor services be covered? Regents Blue Cross Blue Shield currently does not cover these services.
Well, that's going to depend on the health plan. I don't believe those services are part of the essential health benefit package that all carriers are going to be required to cover in 2014. But some plans do cover that, and so I think that is going to be one of the benefits of Cover Oregon, is that you can come in and search, if that's really important to you, if you really want to have chiropractic care, we want to create a place where you can search and say, I want plans in my area that cover chiropractic, and it would give you those options. So I can't really tell you, how many plans will cover it. We imagine probably some of them will, but it's not going to be a requirement as it isn't today.
So I think this may have been a rescinded question, but I'm going to ask it anyway in a more general way, because I've heard this question a lot. As a professional in private practice who is not part of the Samaritan system, how will I be reimbursed for the services that I provide as an independent practitioner?
So currently, we contract with a number of independent providers, and we would continue to contract and negotiate that contract with each provider as we do now, and make sure that we are offering an affordable reimbursement, which is consistent, that we would pay regardless of who your employer is. So that methodology and that approach that we've been using, as I mentioned, for the last 17 or 18 years is the one that we would continue to move forward with, in terms of making sure that we're equitable and being inclusive as possible in terms of people willing to contract and negotiate with us and meet those requirements. That wouldn't change.
Will it be capitated?
Hold on. So the question was, will it be capitated? We have some providers right now that are already capitated. And certainly that's part of what Kim was mentioning in terms of different payment methodologies, and that's something that we're looking at as we create our pilots and as we move forward with transformation. How will we do that, and how will we move forward with the different alternative payment methodologies?
Oh, yeah, you did. I was just going to say that payment, the transformation, and looking at how you pay your providers different, and as Mitch mentioned, how that incentivized how care is delivered is one of the things that we are required to look at in our transformation plans, and we will be doing just that.
The success of this is going to be about how creative communities can become in changing how we pay for care. Right now we pay for quantity, we don't pay for outcomes and quality. And I think as all of us now agreed, we also have a very administratively difficult payment system, both for providers of care as well as for those of us who get it. And I think one of the clearly stated goals of this healthcare transformation has been we need to figure out how to pay for care differently. To be honest, no one knows ideally at the provider level how to best pay for care. And we're looking at these 15 CCOs around the state to begin to change how they pay for care, to look at what works, and to share with each other across the state what's working and what isn't working. And hopefully we'll get to a better place than we're at now.
The supply of primary care providers in this area is already limited. In Corvallis, finding a new primary care provider involves weeks of waiting, assuming that one can find a provider taking new patients at all. What is the federal government, state, and/or CCO doing to recruit more providers to cover our current population and that larger the larger insured population to come in 2014?
So hugely important question. Let me answer it from a couple of different ways. One, part of our agreement with the federal government in doing this healthcare transformation with CMS was we as a state are going to make an investment in some loan repayment programs specifically geared at attracting more and more primary care providers to communities around the state. So that's one thing. Number two, we're going to look at some of the ways around the state that we've had some successful programs that have subsidized malpractice coverage for some of our rural primary care providers, particularly those that do obstetrics, and that's been a volume issue. And I think the third thing, and most important thing, is going to be to begin to get at changing how care is delivered. Right now, it's pretty clear we don't have enough primary care clinicians to cover all of our needs in the way healthcare is developed now. But think for a minute back to the story of Malik. I'm a family doc. I used to take care of a lot of kids with asthma. And quite frankly, the sicker they were, the more I got paid. And the sicker they were, the more often they came to my office. And if I was seeing more and more sick kids with asthma, I'd hire another primary care provider. Under this new way of thinking about healthcare, what we know is that by doing such things as sending a community health worker out to the Maliks of the world's house and getting rid of the things that make him wheeze can actually be very successful. No one ever paid me as a primary care doc to send a community health worker out to someone's house. I only got paid when they were sick. But imagine for a minute if we start to really focus on how we can begin to keep people out of the office rather than in the office. I think we're going to perhaps, we need more of a different kind of a workforce. We may, it turns out, have enough primary care doctors. We certainly don't have enough community health workers, a whole variety of non-traditional health workers that can be a part of our workforce. So, the short answer is right now, the way we deliver care, no, we don't have enough. But I think rationally, we can start to change how care is delivered. We're going to need some non-traditional healthcare workers. We're making some investments in that. We're trying to attract more primary care providers, and we're going to have to right-size our system. It's going to take a while. It takes about 7 years to fully cook a primary care doctor from the beginning of medical school to when they finish residency. It takes 2 to 3 years to fully cook a physician's assistant. And we've got to look at a whole variety of ways, different kinds of nurses, different kinds of non-traditional healthcare workers.
I think I would just add from a community perspective, as Samaritan Health, collaborating with Western University and opening the medical school in Lebanon has really already added to our ability to recruit and retain qualified physicians. Many of the studies show that where a person would go to medical school and do their residency and do their training, if they're choosing to go there for school, they also are have an infatuation with that area and with that environment and would be more likely to stay in that area than to leave. And so by having that medical school, that's already afforded us the opportunity to have some additional primary care providers in our service area, which some have already started practicing through that program. So that hopefully that will be another outlet as well to help broaden the opportunities for providers to be available.
We have about 20 minutes left, and lest you worry, there were lots of questions about single-payer healthcare and Representative Denbrough's bill. We're going to do that last, so I will save time for those questions, lest you worry. How does the CCO adequately share the burden and benefits of preventative care with county health departments and county city governments?
Well, we're working on it. We haven't, 105 days, we don't have anything to burden yet or a share, but that would be something that as our stakeholders, as we get together through whether it's regional planning, through finance, through population health, through all the pilots, how do we look at what's available and how do we, if there's savings, how do we address that? What do we do with that? How do we reinvest that back into the community, back to population health and share that? And those are all the discussions that would happen at that community level with all of the stakeholders at the table.
Yeah, that's the question that all the health department directors and deputies are asking right now. It's an area that wasn't really teased out very well in the legislation, as Charlie had said, but yet many of us see that that's one of the critical areas to really, get ahead of the curve in terms of this. But again, you can't invest in it until you have some savings to invest. And so what's happening in our CCO, and I would assume most of them around the state now, is you're first looking for the low-hanging fruit. What are the things that we could try and change right away? So our transformation plan's looking at what are the things that we think have the greatest chance of some success to maybe save some dollars now, because if we can save some right away, then we can start thinking of strategies about how to reinvest those longer term to move further upstream. But you got to get a toehold with some savings first, and so we first look at these. And in the meantime, the conversations are happening and the partnerships are building. I feel really fortunate within the CCO we've developed that we're very engaged between the county and the CCO. It feels like a real partnership. We're all sharing different pieces of the work, both in just doing the basics, but also in understanding each other's systems. When folks in our shop are worried about this, I say, well, don't worry about it. Kelly's got her degree in public health. Oh. So, she knows what we're talking about here. So anyway, so we're working on that. I think that we all see that that's the goal, to move further upstream. I think not just with the CCO. I'm involved in a project with United Way locally that's really focusing on how do we start visioning working in our community with all the partners about moving upstream. That this idea is you can continue to do what you're doing and fulfill your mission and meet lots of needs, but shouldn't you stop and take a look at that mission and say, is there a better way to address this or to prevent it, and how can we move everybody to think that way, and that's going to benefit the whole community.
Ultimately, this isn't just about CCOs and public health departments. Think about it for a minute. If we're going to have functional community healthcare systems, that's going to mean all the providers, all the community groups, all the insurers. You can't let anybody off the hook around community health. I think that's what we're trying to create and start through these CCOs, is a place to begin that conversation.
What is the current interest from insurance companies to be a choice on the exchange, given the extra oversight and accountability measures to which they will be required to respond?
Well, as I mentioned before, we're feeling good about the number of carriers that are going to participate in the exchange and the level of choice, level of plan options they're going to provide. I can't share with you any specific numbers or names or anything like that. We did receive letters of intent from insurers that want to participate in the number of plans that they want to offer. We need to keep that confidential for a bit. It's as part of the contracting process as it goes forward, but based on that response, we think there will be good choices available. I mean, we really think the exchange is going to provide an additional market for insurance companies, so we think it's really smart of them to participate. The exchange is the only place where you're going to be able to get access to tax credits and cost sharing subsidies, and as I said, those income levels are pretty high, so that's a majority of Oregonians who are going to be eligible for that assistance, and so they're going to want to go through Cover Oregon. So if you're an insurance carrier and you want enrollees in Oregon, you're going to need to be on Cover Oregon. So so we're pretty confident right now in terms of the number that are going to participate.
Please discuss personal responsibility for diet and exercise for better health. And save time for single-payer health care, which is helpful.
My 2 cents about that are, I think, again, it's a hugely important issue. We're going to have to figure out how to enhance knowledge, responsibility, not just personally, but also there's an industry-wide sense of responsibility. We've got some things around calorie labeling, around a whole variety of things that hopefully will move us in the right direction. But it's a huge, and it's going to be a very contentious public policy discussion about how we do that.
Quick one, are assets included in the income calculation for financial assistance?
No, it's just your yearly household income.
Okay, so I'm going to move on. The rest of these are, so we have 3 more cards. If Dr. Goldberg and I finish answering these questions, we'll get to the 3 more cards.
Okay.
But these are for Bruce and myself. Question for Dr. Bruce Goldberg. With so many independent studies concluding that the single-payer model has the most potential for controlling administrative costs, can you give us some reasons why the governor and the Oregon Health Authority does not endorse moving in that direction? And do you support, and question for Dr. Goldberg, do you support the idea of single-payer health care? If yes, when and how do you see it being established in Oregon? If no, why not? And when he's done, I have a couple of cards asking if I will co-sponsor Representative Dembro's single-payer health care bill.
The answer to that, the first one is that it's sort of the Willie Sutton theory of healthcare, which is go where the money is. Absolutely, there's a lot of administrative waste, but certainly most of the healthcare dollar goes to care. And right now, what we're trying to focus on is making that care more affordable, more efficient, and more effective. So there's no doubt that a single administrative structure would make this easier. I think we have that in Medicare. I think at the point that politically we move towards that in this country is going to make a whole lot of sense. Right now, the governor's focus, my focus, is how we can focus on how care is being delivered. Whether we have a single payer or a multi-payer, eventually we are going to have to focus on how we can make that care more efficient, how we can have that care work for us to make us healthier. Indeed, we're going to have in this country and in this state, I believe, a long political debate about how to provide healthcare services, and that's going to go on for quite some time, and in the meantime, we're going to focus on how care is delivered.
So the questions for me in various forms were, would I support Representative Dembro's reintroduction of his bill from 2011, which would call for single-payer health care in Oregon, and do I support single-payer health care? And it's kind of a 2-part question. Dr. Goldberg talked about having a little bit of a rant earlier about lack of transparency and all of these questions. I felt my own internal rant building in the answer about reimbursement. And I was thinking, when I go to the grocery store to buy my groceries for the week, it's not difficult to figure out how I'm going to pay the grocer. I'm either going to write a check, pay some cash, or use a credit card, but the total is always going to be the same. I know what I'm going to pay, the vendor knows what the vendor is going to get. I don't understand why healthcare is the only product and service for which that isn't the case. It doesn't make any sense. And from my way of thinking, the only way to fix that is to have a single-payer healthcare system. where you pay in one way, you have one price, we know what the cost of an MRI is, we know what the cost of getting some ear tubes put in are, we know what the price of an annual exam is, and it all runs through one place. The reason I think that's the case is I think it matters less who pays for it. I think the issue is when we get into systems where people are competing to have panels and negotiating who's going to be your provider based on the deal that you get in order to be on that panel. How much are you willing to forego getting paid so that you get those patients that are part of that panel? So that the answer to the question is, I personally very strongly support single-payer health care, and I wish that we could get there faster. Now, serving in the legislature, one of the things that I've learned in the last 7 years is as much as I would like to have a magic wand and get to have everything my own way, I am reminded on an almost daily basis that I don't get what I want most of the time. And the better way to engage and be successful in moving things forward is to try to figure out what's feasible to move the ball forward at this time. I don't see, and someone, I don't know if they're in the room right now, but I glanced through my email before I came, and there was a question about this. Why do you say that it's not a feasible thing to move forward? I can tell you from talking to my colleagues, there are not the needed 31 votes in the House and 16 votes in the Senate to be able to pass that and make it happen. I do think that what we can put our energy towards in the upcoming session is continuing to go down this path of healthcare transformation in the state of Oregon. If we get there and we continue to make progress, I don't believe it's going to be a perfect system. I think there will be problems in that system. I don't think a perfect system exists, but I think it will be vastly better than where we've been. And I think it will move us closer to a place where the American public and Oregonians have more comfort discussing the idea of single-payer health care, and we're probably going to have to come up with a different name for it than calling it single-payer health care, because people hear that, it's like, oh my gosh, single-payer health care, what are you trying to do to me? Yeah, socialism, whatever it is that you want to call it. So, and people have also fears about the CCO. Anytime that we have change in healthcare, which is a tremendously personal thing, healthcare and education, if you want people to get invested and you want people to get angry and you want people to get afraid, talk about changing healthcare and education. So I don't know the answer to the question. I talked to Michael today, and now I wish that I'd asked Representative Dembro what his plan is with this bill. I don't know what his plan is. I'm sure some of you have talked to him and know what his plan is. I don't know right now whether I would sign on to it or not. If I did, it would be more of a statement of my ongoing commitment to moving in that direction, but I just simply don't see us going there. I plan to spend my time and effort in the coming months really helping us to move the ball forward, hopefully being a conduit for all of you for the questions that you have, to be able to just keep popping up the questions that people are going to have as we move forward. You're going to have questions, I'm going to have questions, and there's going to be parts that are hard. So I look forward to hearing more about that from all of you. We have about 5 minutes left, and I just wanted to thank our panelists for coming tonight and answering so many questions. We had a handful of cards that we didn't get to, but we did get through a lot. I'd like to thank all of you for asking good questions and being patient with, I know what can be a very frustrating format to not have your own voice asking the question. But as I said, we'll be following up. I will schedule another meeting here in the near future where we can just all sit and have a back and forth conversation, and I will share that information back with Dr. Goldberg, who can tell you I forward questions from people all the time.
That's great, that's how things get done.
Yeah, it's hopefully how things get done. And on the mental health question that came up earlier, the payment, the provision, there are a couple more mental health questions in here. We are going to follow up with that in February or March as things are moving forward, to just continue having this conversation as a community. So with that, I thank you all very much for coming. Again, check, if you have access to Facebook, it'll probably be a day or two before that document gets posted with all of the questions. And I'll include the link to the YouTube video. I think this is the first time a forum has been videoed, so that's exciting and new. Thank you for doing that. And we'll also send it out in the next e-newsletter. We'll attach the document. That'll probably be coming later this week, along with the link to the video. Thank you all very much for coming.
www.coveroregon.com for the exchange. and health.oregon.gov for information about CCOs and a bunch of other things about healthcare, the Oregon Health Policy Board. Health.oregon.gov, coveroregon.com.